So hematology. So hematology is, I don't know, probably second place to most confusing subject, right? Oncology, probably first place. All right, so luckily we're not talking about oncology in this course. But hematology, oncology, those guys like to make up numbers in Roman numeral. They also like to not explain what things are called. They just say, no, that's an HB1AC, of course, right? They don't, so it doesn't, it's all over the place, right? So we'll try to make it as clear as possible, right? There's not many like interleukins you have to know or tumor necrosis factors you have to know, but we'll spell them out if we have to, right? So we'll talk about the RBCs, right? We'll talk about the white blood cells. White blood cells have like a multinucleated neutrophil, and we got to talk about platelets, which is little sheddings that we'll be looking at, right? Platelets, we'll talk about a lot of stuff. We'll talk about like DVTs and PEs. That's called VTE, right? We'll look at PAD, which is like an extension of ASCVD. It's like I thought hematology was easy, right? So yeah, so ASCVD we talked about in cardiac, right? You had anginal chest pain. You can have chest pain of your legs, all right? That's called what? When you're walking, and you get pain in your legs. It's called intermittent claudication, and that's due to cholesterol, right? So we'll talk about PAD, and it's usually due to same kind of deal. We want to give antiplatelets to stop that from happening. All right, we'll talk about white blood cells a bit. We'll talk about RBCs to start off. So RBCs are just one cell line right here, right? There we go. So the RBCs are one of the cell lines from our multipotent hematopoietic stem cell. So your stem cell, right? You hear about stem cell research, stem cell this, stem cell that. The stem cell can be divided into any cell in the body. In the bone marrow, it's going to be divided into one of these cell lines, right? So we got our RBC cell line right here. Of course, we're in the bone marrow first, and then once they graduate, then they can go off into the blood, right? Sometimes some of these guys will be pushed out before they're ready, so we'll talk about those, right? Such as like reticulocytes, right? These guys are young RBCs. Those RBCs are not ready for prime time, but they are conscripted. They are drafted for war. Instead of age 30, it's down to like age 18. So now you're gonna have more people fighting, right? And RBCs don't fight, but RBCs are going to be there to deliver oxygen and such, right? And we talked about O2 in depth in 4 different lectures at the beginning of critical care. All right, so they enucleate before they are ready to be ready for prime time. So they like literally take out their brain, right? So they enucleate themselves, and now they are ready for do their RBC stuff, right? We make about 2 million RBCs every second, right? So they're always floating around, always available, always being destroyed. So we'll talk about what happens if you destroy extra. Well, when you destroy extra, you're going to have more of the young guys for sure, right? Those values are going to go up. That's called reticulocyte increase, right? Or reticulocytosis. And of course, you start breaking down more stuff. Then we kind of touched on it when we talked about bilirubin, but bilirubin is RBC waste, basically, right? And there's some cells that will stop, there's some processes there we'll highlight, right? And we got RBCs doing their thing. And just touching on platelets real quick. Platelets, they are they come from stem cell, just like we talked about, right? And they're going to end up as a megakaryocyte. And megakaryocyte stays in the bone marrow, and it just sits there like Jabba the Hutt, and it just peels off like you're taking a yellow fall wrist sock off your patient's foot, right? It just literally just flakes off the megakaryocyte. It's like a huge big crime lord, and people come in there and he just like sticks his fingers into the jacuzzi at 24-hour fitness, and it's just going to waft into the serum, and they're going to do their thing, okay? And we'll talk about platelets in detail, but you've probably experienced this, and that's exactly what platelets are. They don't have nuclei, they don't do anything. They just activate or don't activate. And sometimes we want to not make them activate if they're at risk for CAD, PAD, and the like, right? So platelets are just floating in there, just little white little crusties floating there. We talked about our RBCs, which are in the most amount, right? Those are very, very prevalent, right? So we talked about platelets right there. We talked about RBCs, which can be measured in H&H. You can do H&H, you can do RBCs. Either one is fine, right? They're all going to be low. There's no like disease process where like, oh, well, the RBC is high, but the H&H is low. That's not a thing, right? RBCs are measured, and you spin them out, and you get the hemoglobin hematocrit. So we'll point that out some as well, right? And then lastly is white blood cells, which is all this part over here, right? So we have all the white blood cell piece. We got multinucleated, mononucleated, polymorphonuclear, monomorphonuclear. There's all kinds of different ways to describe white blood cells, but you wanted to kind of get some kind of organization about what types there are, and we're going to be using these types right here. So never let monkeys eat bananas is the mnemonic for the types of white blood cells, right? So L is lymphocytes. Lymphocytes come up on, they have a common precursor, and they eventually go out into the ones you're used to seeing, the B cells and T cells, right? So you got B cells and T cells over here, and those are your L's, right? N are neutrophils. They're in the most amount, right? So neutrophils, never let monkeys eat bananas. N for neutrophils. These guys are the ones that are your heavy hitters. Those are the ones that are fighting off infection. And when you fight off a lot of infection or you have severe infection, we're going to conscript, we're going to bring in, just like the RBCs, we're going to bring in the younglings, right? And those ones are called bands, right? So when people have bandemia, they have extra bands in their white bloods in their bloodstream. That's because they have an infection, a severe enough infection where we got rid of all the adult soldiers and we had to conscript all the new people, right? The new people from age 30 down to age 18. So now we have new people in circulation, and those guys have a soft nucleus, a nucleus that is not polymorphonuclear. So if you look at the difference there, you can say it's more nubby when you have a neutrophil, right? Nubby neutrophils. That's good. I'm gonna write that down. Nubby neutrophils. I'm not gonna be able to read this in 2 years. But anyways, you got nubby neutrophils, and these guys they're polymorphonuclear. They have many. They're one nucleus, but it's all bumpy, right? Like an old pillow that you had from when you're 6 years old. It's like, no, Mom, it's my favorite, right? So it's like it's a nubby pillow. But otherwise, you get a fresh pillow, right out of the store. It's be nice and soft, right? So that's how you tell between a band cell and a neutrophil. Okay, there aren't like bands for eosinophils or bands for basophils or bands for monocytes or even bands for B cells, T cells, right? So we talk about never let, neutrophils and lymphocytes, and then next are monocytes, right? So monocytes, these guys are these are like your undercover operatives. They are always out there, right? They're always out for looking for trouble, right? Not looking for trouble, but looking for crime, right? So they once they identify crime, they're going to take that crime and bring it over to the lymph nodes, and they're going to show it to B cells and T cells. Okay. Monocytes are also in witness protection, or I guess you could just say they're not really in witness protection, but they're undercover cops, right? So they are found in all kinds of tissues. There are some, yes, they're in the bloodstream. There's a certain percentage that are in the bloodstream, right? It usually goes 60, 30, 6, 3, 1% in your differential, and we'll talk about that in more detail. But 6% of your white blood cells are monocytes, right? So monocytes just floating around, but once monocytes make their way into a tissue, it's called a macrophage, right? And you've known about macrophages from basic sciences. So macrophages are the ones that are going to phage things, right? Phage meaning you're going to eat, right? Those eat things, and they're going to also present it to B cells and T cells, and we're going to get an immune response because of that. And then what if there's a monocyte that has gone to the brain? That's called a dendritic cell or a microglial cell. What if that cell is in the liver? It's called a Kupffer cell, right? So you got Kupffer on here too. We've got a Kupffer cell. What if it's in the bone marrow? It's called an osteoclast. What if it's in the skin? It's called a Langerhans cell. It's like, why can't it just be called a macrophage everywhere? What's the deal, right? So there is some differentiation, some specialization, like they know the land, right? Just like you have doctors who specialize in different areas of medicine, like these macroglial cells specialize in, I don't know, MS, right? They specialize in meningitis, right? So they are used to those kind of things, and when they see them, they're like, I see it, and they're going to go ahead and bring that over to B cells and T cells, and they will do their thing and mount an immune response, right? What is an immune response? Well, your B cells, those guys are releasing antibodies. That's their one and only job, is to release antibodies, right? They either manufacture it right now, and they are going to release it in 7 to 10 days. That's why you get better in 7 to 10 days usually if it's a new illness, a new virus, right? But and they'll release little IgM antibodies. And then if it's the second time the B cell is seen, it's like, yeah, they're going to start creating 7 to 10 days later antibodies, but it's like, oh, hey, I know that guy. I know that virus because this guy got exposed to the flu vaccine, for instance, right? I know that flu, and it's going to make antibodies immediately within like 1 to 2 days, and these are IgG antibodies, and they hang around for years, right? And you can see how many you have. Those are called titers, right? You can get like your MMR titers, your measles titers, and you can see, oh, I still have IgG antibodies from when I got my vaccine a long time ago, right? So either you get exposed to measles, which you don't want to be exposed to, or exposed to chickenpox, or exposed to Hep B, right? And then you'll get antibodies made eventually, right? Or we can just give you Vax, and that'll be like the shortcut, okay? So we can mount a response immediately. And then T cells are also, we'll talk about how important those are. Those guys are also going to be releasing a lot of chemicals that are going to mount this whole immune response. Those chemicals are, there's going to be a lot more arrows on this page if I told you what T cells do, right? They're going to be going to every single one of these cell lines, increasing them. They're going to increase a lot of things. They're going to attract things to different where the bacteria are or pathogen is. They really mount the immune response, okay? And who else are we missing? So we got neutrophils, lymphocytes, monocytes, eosinophils, and basophils. Don't really care. All right. CBC overview. All right, so our CBC, we talked about the white blood cells, right? About 4 to 10K is your normal white blood cell. It can be high or low. So if it's high, it's called leukocytosis or neutrophilia, maybe, if the neutrophils, which are a type of our white blood cells, are high. Or it could be low, right? So leukopenia or neutropenia. Those are a condition where your white blood cells are low. We know white blood cells are important to fight off pathogens. So of course you're at risk for infection when your white blood cells are low. And we'll spend some time with white blood cells, right? But white blood cells can be high or low with infection. Like we talk about SIRS criteria. SIRS criteria can be due to a high white blood cell count or a low white blood cell count, or high temp or low temp. Usually with severe infection, your white blood cell counts will get utilized. It'll get used up, it'll get consumed. It's consumptive. And therefore you can't mount enough white blood cells, especially in someone who's immunocompromised or has severe sepsis or elderly, etc. Right? So high, low white count, and then high, low H&H, right? So H&H about 15-ish. So 15-ish is a normal hemoglobin, and really that's only the value you have to know because hematocrit is going to be 3 times that. All right, so hematocrit's 15, or sorry, hemoglobin's 15, hematocrit will be 45. Hemoglobin's 8, what's the hematocrit?
21.
7, if it's 7, it'd be 21. If it's 8, it's 24, right? If it's 9, it's 27. If it's 10, it's 30, right? So that's hemoglobin and hematocrit have a 3-to-1 relationship, right? Sometimes you can be more dilute, and it might be a little bit off, but for the most part, it's a 3-to-1. When we spin down the RBCs and we let them settle at the bottom, right? That's your hemoglobin and your hematocrit, right? Or that's technically your hematocrit. Your hemoglobin is a little bit different, but either way, we can have an H&H measured from our blood sample, and then everything settles out. We got our plasma there, and we have our white blood cells that we just talked about. Our white blood cells and our platelets are going to be in this tiny little layer in between. It's not really that measurable, but that's your buffy coat. That's where you have all your stuff and your the different things might settle down there too, like fibrinogen and such, and other heavier proteins. But those guys are going to be that's where they are. That's where the components kind of lay out. Okay, so H&H is about 3-to-1 relationship. All right, why would it be low? It's usually because you're missing some kind of building block of the RBCs. You're missing iron or folate or B12, right? Those are the top 3 that would really cause you to have a low H&H or low hemoglobin. Also, just straight up bleeding, right? If I'm bleeding, I'm going to have a low platelet and a low RBC because I don't just bleed RBCs. I bleed platelets, and yes, I technically bleed white blood cells too, but I'm going to see my platelets and my RBCs go down or my H&H go down when I am bleeding, right? So looking at medications, prophylactic medications like VT prophylaxis, those could definitely cause my H&H to be on the low side, right? So malnutrition is an important reason. Cirrhosis is an inflammatory state, so is chronic kidney disease, right? I think CKD might be on there, but CKD, cirrhosis, those guys are chronic inflammation, and inflammation itself inhibits erythropoietin, which is what makes RBCs be differentiated from that stem cell we just pointed out. So that could be a reason why, but also in CKD, you're missing what? You're missing erythropoietin, right? So that will also make my RBCs low. Why would my RBCs be high? It's usually because of chronic hypoxia. It's usually the most common reason why we have polycythemia or chronic hypoxia, because hypoxia also stimulates RBCs to be produced, right? So if I have chronic hypoxia, or I'm running the Tour de France, right, and I want to do really good in the Tour de France, I'm going to get testicular cancer and lose a ball, or I'm going to go to the top of a mountain and I'm going to get used to making more RBCs, right? That'll increase my own erythropoietin, or I go to the side street, to the side alley, and get a dose of erythropoietin. Either one, okay? But it's legal to go to a mountain. It's not legal to dope in the side of an alley. It's still legal to lose a ball. And what else? We got platelets. So platelets will be low when you're bleeding. Platelets will be high when you have a stress response, right? When it's more than what's too high of a platelet count? That's called thrombocytosis. I have too high of a platelet count. Usually stress will do it, and we're not really concerned when it's high, except when it's higher than what? 450, maybe? A little higher? 500? It's 1 million, right? When more than 1 million, then you're concerned about platelets being too high, right? We talk about platelets being high when it's like over 1 million. It can cause your potassium to start going up and starts hemolyzing a little bit. But also you're at risk for thrombotic events when your platelet count's more than 1 million. Okay, that's usually because of like a cancerous process. It's very uncommon for that to happen regularly. Whereas it can be common when you have leukocytosis, right? You can have leukemias that might raise your white blood cell count to more than 100,000, and that's when that starts causing thrombotic events. Okay, so we kind of touched on the fishbone, right? The H&H is in the middle, white blood cells on the side, platelets on the right, right? So, and we'll kind of talk about these in more detail, what causes changes in each, right? So platelets, we have a whole section on platelets. Hemoglobin hematocrit we'll spend more time on, but again, it's a what relationship? Is it 1 to 3 or 3 to 1? It's 3 to 1. So the 3 is the hemoglobin, hemoglobin hematocrit, not hematocrit hemoglobin. Don't be weird, right? Don't report out, hey, the hematocrit hemoglobin is 30 and 10. It's like, what are you talking about? It was 10 and 30, right? So it's hemoglobin 10 to a 3 to 1 relationship times 3 is going to be up to 30. Okay, and we'll touch base on some of these other guys as well. So these other studies we can do to look at RBCs, right? So when RBCs are low, then we start looking at these other values here, right? We start, why are they low, right? So that's what's going to tell us why they're low. So we look at MCV, the mean corpuscular volume. We look at MCH, the mean corpuscular hemoglobin, and then the mean corpuscular hemoglobin concentration, the corpuscle being the RBC, right? We never look at really mean platelet volume unless you're like looking at some like cancerous kind of situation. But we talked about platelets, we talked about RBCs and white blood cells, and we'll dive deeper just a little bit on each one.